I recognize the gentleman from Texas, Mr. Farenthold.
Thank you, Mr. Chairman. I want to follow up before I go into my line of questioning with Dr. Lori. You talked about an overabundance of caution. It's why we closed the bowling alley. It's why the airline took out the seats and reupholstered and recarpeted. We're hearing a lot about an overabundance of caution. From a purely health standpoint, would an overabundance of caution include an air travel ban complete to the affected countries like we've seen in some European countries?
No, I don't believe it would.
All right, I'm going to respectfully disagree. Now, I'm glad we're having this hearing today. This is my second hearing on Ebola, and I was actually really disturbed during the first hearing that the Homeland Security Committee had in Dallas to see the CDC pointing fingers at CBP pointing fingers at the National Institute of Health. It's one of the reasons I said we needed to appoint somebody to be the point person, someone where the buck stops. And the President chose Mr. Klain. I'm going to join with Mr. Gowdy in being a little skeptical of putting a lawyer instead of a doctor in the log, but Josh Earnest told reporters ultimately it will be his responsibility to make sure that all the government agencies who are responsible for aspects of this response, that their efforts are carefully integrated. He will also be playing a role in making sure decisions get made. I think one of the key things in that role is working with Congress, and I think he should be here today or at a hearing to be called very soon. We're the ones that signed the checks. We've already signed a $750 million check to fight this Ebola. I think he needs to be here. I also, part of the finger pointing we saw was the CDC saying the nurses in Texas broke protocol when I think they were following to the best of their ability what they were able to do. I think it was entirely inappropriate they threw the nurses under the bus. My wife is a nurse, and she and I were both were individually hurt and offended by that. I think these nurses were doing the best they could. And listen, an Ebola patient isn't always going to present at an Ebola center. They're going to show up at their local hospital when they show symptoms. Every hospital needs to be trained. And Ms. Berger, am I correct in saying your testimony is, what was the percentage that weren't prepared?
I believe it's 85 to 86%, but you have to remember these are voluntary guidelines. They're not mandates. And until there is a mandate from Congress or the President, we will continue to have.
I would think it may be I'm not a big fan of big government regulation, maybe the joint commissions or the states. Mr. Chairman, I'd also like to enter from the record a statement from Texas Health Resources. They were also thrown under the bus, and this is one of their responses to that. So I'd like to enter that for the record. Now, we've talked about who's not here. I want to talk about, since we do have Mr. Lumpkin and the General here, I wanted to ask a couple of quick questions about our military involvement. General, why did you join the military?
Served my country. My dad was a Marine.
And traditionally, the military's job has been to serve and protect this country with guns and bombs. I understand the mission is expanding, and you all are out now building health facilities in Ebola-plagued areas. Very laudable, but is this really what the military was designed for? Is this? It seems like if you wanted to build health care facilities and help countries, you'd have joined the Peace Corps and not or USAID and not the military.
Sir, as Mr. Lumpkin stated, this is a national security threat, and as has been stated previously, the idea has been to fight this overseas so it doesn't further come back.
But is the military the only organization that can build hospitals, morgues, and treatment facilities? Aren't there thousands of, if not hundreds of thousands of contractors worldwide that can do that?
Absolutely, but we were asked to use our unique capabilities, as was stated further, to jumpstart this process, get it in place so we could turn it over to those organizations.
And so are these facilities going to be near existing facilities where Ebola patients? Are they going to be greenfield facilities or brownfield facilities? Are the locations nearby where patients are going to be congregating?
We've been asked to build treatment units and locations that were coordinated between USAID and the government of Liberia.
So very possibly you could be working on an expansion to an existing hospital that's treating Ebola victims. within those guidelines. Mr. Lumpkin, you look like you want to jump in on that.
No, of the ones we've been asked to construct per USAID, none of those are expansions. They're all unique, new Ebola treating units.
And so then you talked a little about PPE. What personnel will be wearing PPEs? Are they, I mean, you got 80-degree plus highly humid conditions in these countries. And the natural inclination is going to be, why do I need to wear this Tyvek suit?
That's a great question. So the protocols that will be followed are that all U.S. military personnel will be issued a basic set of PPE that they will have with them in country, but because of the temperatures and because, quite frankly, of the jobs they'll be doing, they will not be required to wear it all the time.
I got one quick last question. There's been a lot of confusion about this 10 days and then 21 days. After the 10 days in Africa, they're going to come back to the United States and go to their unit and be monitored at the unit. Between the 12 hours that they're not being monitored by their unit, are they going to be able to ride a subway, see their girlfriend, go to a bowling alley, and take an Uber?
They'll be on the military facility. They will be allowed to go home, either to the barracks or to their families, but obviously every 12 hours will limit their ability. Having to report to the unit every 12 hours will limit their ability to travel much further off base than you could go in order to get back for evening formation.
But you will be, all right, thank you very much. My time has expired.
I thank the gentleman. Now recognize the distinguished gentleman from Illinois, Mr. Davis, for 5 minutes.
Thank you very much, Mr. Chairman, and I want to thank Chairman Issa for calling this hearing. I think it's been very instructive, very helpful, and I want to thank all of the witnesses for appearing and being with us. With O'Hare Airport being one of the busiest in the world, and with Chicago, where I live, being an absolute transportation hub, where millions of people come to and through our city each and every week. I first of all want to commend our public health officials under the leadership of the Illinois Department of Public Health and our city officials and Homeland Security for what they have done in terms of preparation to screen individuals as they come, to have places they can go should anything be detected. Our hospitals have been fully cooperative, and I commend all of them. I also want to commend all of our health workers who are the frontline individuals, because while others can stand and cheer from the sidelines, you're in the arena. You're actually there. You're not the spectators. I've heard a great deal of information, and I'm delighted to live in a country that is willing to use some of its resources to be available in such a way that it does play and understands an international role. So I want to thank AID and our military for being in West Africa. I agree with those who recognize that we don't have enough resources there to actually do all that we can and all that is needed to be done. But I commend us for the effort, and I commend us for what we are indeed doing. I think I have a little more confidence and a little more faith in CDC and our health professionals, because every day, as I understand it, our protocols are under review, that whatever has been established, that's for right now, but with every incident, we are learning new approaches, new techniques, and we're putting those into play. And so I'm not sure that I have as much gloom and doom, because we've had crisis before, and we've found a way, and we'll find a way to stay ahead of this one. Dr. Laurie, let me ask you, notwithstanding the advances that we've made in medical science, infectious disease continues to cause millions of deaths every year throughout the world. And we know that the primary strategy has been vaccination, developing vaccines. Let me ask, are there other strategies and other approaches that are being used relative to human behavior, activity? I always remember my mother, who didn't have any medical training, but she always told us that an ounce of prevention was worth much more than a pound of cure. Are we able and are we doing things that can help prevent and arrest the impact of these infectious diseases?
I very much appreciate your question, Congressman. As a primary care doctor, I see, every time I see a patient, how important communication is, both with my patients and with my community. One of the challenges of dealing with this outbreak in West Africa has been that there are a lot of deeply held beliefs. There has not been sufficient information about how one contracts this disease or how to prevent oneself from getting it. And I believe that there's been a tremendous effort at public education. And I expect that that's going to continue in the days and weeks and months ahead. Here at home as well, there have been efforts to educate the public, but many of those have centered on the populations whose heritage is in West Africa. And in the areas of the country where those populations exist, state and local public health departments have shown tremendous leadership in reaching out to those populations, helping them understand how to recognize and protect themselves here, and importantly, helping them provide information for their families in West Africa, whether it's on the Internet, whether it's by Skype, whether it's by text, whatever. There is certainly much more public education and outreach to do, both in West Africa and likely here, but I really applaud your observation because it is centrally important to anything that we do in medicine or public health.
Thank you very much. I thank you, Mr. Chairman. I know that my time has expired, but I'd just like to say to my colleagues who are concerned about the czar, it occurred to me that there are those of us who know things, but then there are those who know how to make things happen and how to get things done. And I think the President may have had that in mind as he made the appointment. I yield back.
We thank the gentleman. Now recognize the gentleman from Kentucky, Mr. Massey.
Thank you, Mr. Chairman. Mr. Lumpkin and Major General Lariviere, as you already know, there are members of Kentucky's Air National Guard in country, and so I hope you'll understand that my first questions will be focused on their safety and training and well-being. But I need to ask Dr. Lurie a question first. Are you familiar with the treatment of the 3 patients in the United States, the treatment regimen that they've received? We've heard in the press that they received ZMapp and also perhaps blood transfusions. Is that true?
So there have been more than 3 patients treated in the United States, but I have some familiarity with their treatment, yes.
Right. So does it include blood transfusions and ZMapp?
So my understanding is that some patients, certainly early on, received ZMapp when it was available, and some of the patients have received blood transfusions.
So the best minds that we have, the best doctors that we have in this country, their consensus was that that would be the best treatment for them. Major General, my question to you is, can you assure us that the best treatment available in this country will be available to our soldiers in the unfortunate circumstance that any of them contracts Ebola?
Yes, sir, absolutely. As I stated earlier, there will be a Role 2 hospital both in Monrovia and in Senegal, where your Kentucky National Guardsmen will be stationed, that's there to exclusively take care of U.S. military personnel.
And when they return stateside, will they have access to ZMapp and blood transfusions if that's what the doctors prescribe?
Whatever the doctors prescribe, it'll be available for them.
Okay, thank you very much. Mr. Torbay, you seem to be sort of where the common sense resides here, because you've been on the front fighting Ebola, and I really appreciate what you've done over there. And clearly our futures are linked with West Africa. We want to see it solved. We want to see it cured over there. And some of the things that you've mentioned today about gradiating people into no risk, low risk, and high risk, and then treating them differently instead of a one-size-fits-all makes a lot of sense to me. My question to you is it possible, not likely, but is it possible to contract Ebola by sitting next to somebody who's exhibiting symptoms on a bus?
Thank you for your question. First of all, for the record, I'm not a doctor, so I cannot be very specific when it comes to that. But from what we learned is unless there's contact with bodily fluid.
Would that include perspiration?
That could include perspiration.
And do you have to contact the skin, or could you touch somewhere that an Ebola victim has touched?
I can't answer that. My understanding is it has to be through a broken skin, but I'm not really sure about that.
So do your protocols, but would you say it's possible, even if it's not likely? Your protocols that you described before say that somebody who has a classification of low risk is prevented from taking public transportation. So surely you foresee that somebody, it's maybe not likely, but is it possible that somebody could catch Ebola on a bus?
We haven't experienced that. You know, with Ebola, it could be possible. There's no scientific evidence that proves it or proves against it.
There's no scientific evidence that it can be transmitted through saliva, vomit, perspiration?
Saliva, vomit, perspiration, yes.
Okay. Does it live on surfaces? Can it live for more than 15 minutes on a surface?
I cannot answer that.
You can't answer that?
I do not know the answer to that.
Well, maybe Dr. Lurie can. Can Ebola survive outside of a patient on an inert surface for any period of time?
It can survive on an inert surface for variable periods of time, depending on the temperature and humidity.
Then let me ask you, is it possible, I'm not asking you is it likely, is it possible that somebody could contract Ebola sitting on a bus next to somebody who has it? Can you imagine a way that could happen? Is it possible?
One would have to have been in contact with the body fluids of that person.
Does that include perspiration?
It does include perspiration.
Okay. Major General, I want to get back to our soldiers here. You've assured us that they've been adequately trained in avoiding the contraction of Ebola. If a soldier came to you and said, Major General, is it possible, not likely, is it possible to contract Ebola sitting next to somebody on a bus who has it? What would your answer be to them? And I trust you're going to give us a straight answer.
So I would defer to the medical professionals, as the doctor just said. It can be transmitted through sweat, bodily fluids has been noted, and I would say that that is why we have the 3 feet separation. That's why we don't.
So if I'm a soldier and I asked you that, sir, what would your answer be?
Well, I guess my answer would be it's a hypothetical.
It could certainly happen.
It could possibly happen.
I'm asking you to answer a hypothetical then.
I am. You are asking me to answer a hypothetical. So it could possibly happen, but I would defer and say low likelihood, and you need to follow the procedures that you were taught in your training session.
I'm hoping they're getting the best training possible, and I'm concerned if they're being told they can't catch it on a bus. Can you tell me what your answer to the soldier would be if he said, sir, can I contract
Well,
Ebola?
so I mean, for the record, they're not getting on buses with Liberian citizens, and your Kentucky Guardsmen are actually in Senegal. So,
understood.
We
have other members from Kentucky serving in the military that are going to be in, I understand it, hot zones.
And Fort Campbell folks will be there, obviously. Right. But they won't be getting on buses with Liberian personnel either, and so they will. I would tell them to go ahead and follow their protocols.
So just quickly, our confidence has been shaken in the CDC because we get conflicting answers. Right. And when I first heard the military was going overseas to combat Ebola, I was skeptical. But then on second thought, I said that's where our competency in the government resides, where the confidence resides in the American public is with our military and their ability to focus on a mission. Today, you answered some questions where you deferred to CDC guidance. For instance, whether they should be quarantined for 10 days in country or 21 days in country. What I'm asking you, for the safety of the soldiers and for the safety of the public, is to use your own judgment. We trust the military, actually, more than the CDC on this. So please use that to guide you.
No, absolutely, and that's why I'd reiterate that once they return, we are having not the self-monitoring, but we're actually exceeding CDC standards because we're the military of having those individuals monitored by their units once they're back.
And the public, by the way, would like to see them stay on the base for the 21 days after they're back.
And I understand their concern, but and again, this is the we think that it's prudent to have them check twice a day on base, but be able to return to their loved ones in the evening.
Well, what we appreciate is your mission is and always has been to protect this country, and we appreciate your service.
Thank you.
I thank the gentleman. We now go to the gentlelady from New Mexico.
Thank you, Mr. Chairman. Clearly, with the arrival of Ebola in the United States, we are all in this committee really concerned about whether or not our emergency preparedness systems are effective and whether our public health system is an effective response mechanism. And I think I share with everyone in this committee that we're concerned that we've seen protocols have to be adjusted, that we wish we'd had better training, that we're concerned about hospital responses. I would just add, particularly after the last statements, and I don't disagree that we want the highest standard of response, but a multitude of responses that are not based on scientific evidence and best practices, if they're not, they aren't sound, then we create even more confusion and more panic by individuals, and we can't really manage a public health or an emergency systems response. Those are clear lessons that I learned as the Secretary of Health dealing with, I wasn't there to deal with hantavirus in New Mexico, but we had those experts certainly there. But I was there for SARS, for potential pandemics, for not having enough flu vaccine, and I'm still there dealing with one of the worst hepatitis C issues in the United States. So unfortunately in New Mexico, we know how important it is to have a good, solid, strong public health and emergency response system. To that end, I know that we've been both critical and we've recognized that whether or not Congress invests sufficient resources in the CDC and the NIH and all of our other partners that have a response to emergency preparedness, we expect that there is still in place a robust response. But I want to be clear that has the fact that these policymakers have failed Congress to invest appropriately and have cut funding, has that had a negative, Dr. Lurie, has that had a negative impact on our ability to respond not only to Ebola, but all public health crises?
No, I think that, we've seen an erosion in support for public health at several times in our country's history. And each time that happens, we look back through the retrospectoscope and wish we had done something different.
So I'm not sure I understand your answer. So you don't think that having reduced resources targeted at these issues has had any negative impact?
So we actually just had the opportunity to serve.
Because I will tell you that my public health team will say it is, my hospital association says it is, that individual hospitals around the country say it is, and the fact that you have a decentralized public health system. So even if you had the authority to mandate, you don't have a system that you could do a mandate. And I don't know that I agree, although I really respect my colleague, Mr. Connolly, that you want to mandate here. But we have another issue in this country, which is we do not have a centralized public health system. Your ability to manage state by state by state by state, and I have a poor state with a centralized system, fairly effective, but I can tell you even there it was hard for us to manage all of our county emergency response partners in a crisis.
You're absolutely correct. And certainly we are hearing a lot from states that they are very concerned about the reductions in support for public health and for public health preparedness. And many of them are really looking how they're hard at how they're going to have to cope with the latest rounds of reductions.
And are you prepared now to really think about best practices and more centralized approaches and requiring maybe a different protocol for our public health and emergency response systems in this country? I think if we did that, even when Congress doesn't do its job to adequately fund for these public health issues so that we only react when there's a crisis instead of, and I appreciate someone talking about precautionary principles, that we ought to be proactive in as many cases as we can where the evidence is sound about being proactive in that particular manner. But in fact, I do expect that the Federal Government, even with limited resources, does everything it can to identify what those best practices are and to regularly identify what the risks are if you don't adequately fund and what the impact is to states who also find themselves without adequate resources to prepare and be trained effectively.
I so much appreciate your passion for public health and for the resourcing of public health. It's so important. The way public health is organized in this country by law is that the Federal Government, by and large, can provide guidance and tools and best practices, but the implementation of other aspects of public health is either at a state or local level. And as I think you know well, it's organized differently in different states.
Right. But that's my point, is it may be time to think about whether or not that in and of itself is an effective strategy in this country.
I think it's a very interesting idea.
Thank you.
Gentlelady's time.
I yield back.
Thank the gentlelady. I now ask unanimous consent that page 172 of the CRS report entitled Funding of the HHS Assistant Secretary for Preparedness and Response in millions of dollars be placed in the record. Additionally, I ask, without objection, additionally, I ask that the Wall Street Journal article in the opinion section entitled There's Plenty of Money to Fight Ebola be placed in the record, without objection. Lastly, I would ask that the FY 2014 HHS Appropriations Overview by CRS be placed in the record at this time. Without objection, so ordered. We now go to the gentleman from Michigan, Mr. Bentivoglio.
Thank you very much, Mr. Chairman, and thank all of you for coming today and testifying before this committee on a very important subject. A great deal of importance to the people in my district. And Mr. Roth, quick question: what is the Federal Government's present readiness status to handle a pandemic or other emergency where there is a surge in medical needs in a specific region?
I can only speak to the DHS component, which is what we studied.
Okay. Are you familiar with do you have any idea how many mobile hospitals are in the inventory to be deployed at, well, a reasonable amount of time, meaning 1 day to 3 days, to a region that is experiencing a surge in medical needs, and that's for any reason whatsoever? Another Katrina, hazmat emergency, pandemic, earthquake, tornado.
We did not look at that in the audit that I testified.
Okay, in 14 months of being in office, since I've been in office for the last 14 months, my office has been investigating that need. So the first responsibility is to protect this country, and I haven't found any in the inventory. So there's no mobile hospitals available, no mobile isolation units deployable that can be deployed within hours or days of an emergency. And Ms. Berger, I have a question. You're a nurse. How long have you been a nurse?
43 years.
43 years. My wife's been a nurse for 37 years. So thank you very much for your service. Now I have a question. When a person has any type of infectious disease, whether it's Ebola or the flu, I know they're transmitted differently, but for each step that an infected person makes, does it or does it not increase the risk of its spreading potentially? Thank you. In other words, give me an example. If somebody came down with the flu, it's quite possible that, well, if they stay in their home, the only people that are probably going to get sick or infected from that flu is those people that are in the home. But if any member of that household leaves that house, goes to the drugstore, goes to the supermarket, whatever the case may be. Does the potential to infect others increase?
Well, if it's the flu, if you know you're
Airborne.
and they also have good hand washing, so if you're not in direct contact with the airborne virus going into your eyes by yourself, putting your hands into your eyes or something, that's not likely. But what we're talking about here today is the Ebola preparedness in this country.
I understand.
And it's completely different in this country because there's about 5,000 hospitals in this country and 5,000 ways to manage this disease.
Okay, how many of those hospitals have an isolation unit that is capable of containing the Ebola virus?
Well, according to what the hospitals report on a daily basis in the newspapers is that they're all ready and they can isolate patients at a moment's notice. But what we just got reported to us yesterday was a nurse that thought she, from Kansas City, who has a, quote, negative pressure room, which was non-operable.
Okay, that's one negative pressure room. It's very important, especially with the Ebola, correct, to have that capability?
Correct.
Okay. Now, what I'm trying to get at is if a patient walks in with flu-like symptoms, the first thing they'll do when they go to a hospital is they'll visit an administrative clerk that does some triage, asks some insurance questions. Is that not correct?
Well, if they've got the flu, most of the time they're at home in bed.
Okay. Well, that's not always the case. They could be experiencing fever, and they do come to the emergency room.
If they're seriously ill from
right, seriously ill with flu-like symptoms. So is it possible, what is the protection that a administrative clerk that meets you at the hospital, the receptionist that asks, what are your symptoms, why are you here, what's your insurance, what's the chances of them being infected by an Ebola virus?
The gentleman's time has expired, but she can answer, but you're not talking, you're saying flu-like symptoms, but you're assuming that the person has Ebola in this case?
Correct.
Okay,
Correct.
the gentlelady can certainly answer.
Okay. Again, as I say, several 5,000 hospitals all have different protocols on how they handle Ebola. Some security officers are now asked to step in. They're given little Ebola kits that have a gown, some gloves, and a surgical mask. But I think that that's what we're talking about, is that everybody needs to be trained and prepared and educated on how to handle a potential Ebola patient so that that clerk is also not exposed to unnecessary virus from Ebola.
Thank you very much.
I thank the gentleman. We now go to the other gentleman from Michigan, Mr. Amash.
Thank you, Mr. Chairman, and thank you to this panel for being here today. Earlier this month, several airlines, including Kenya Airways, British Airways, Air Cote d'Ivoire, and Nigeria's Arik Air, suspended flights to and from certain affected countries in West Africa. Our own State Department issued travel warnings to our citizens, urging them to delay non-essential travel to Liberia and Sierra Leone. And recent reports suggest that more than 24 countries have restricted entrance to persons who have traveled to West Africa. So my question is to Dr. Lurie and to Mr. Torbay. Under what circumstances, if any, do you think a travel ban or increased travel restrictions would be appropriate to safeguard Americans?
So I thank you for that question. Over the past week, we have increased and tightened up our screening measures for individuals traveling from the 3 affected countries. You know, they're all now being funneled through 5 major airports. They get screened before they leave. They get screened when they come. Every passenger coming from an affected country now has their information given to the state and local health authorities, and they will be actively monitored for 21 days. So we've really tightened that up quite a bit, and I believe it should be sufficient.
But how about a travel ban? Is there any circumstance in which you would support a travel ban?
We think a travel ban would be incredibly unproductive or counterproductive.
In what ways?
Well, first of all, right now, we have a really good mechanism to identify and track every single person coming now from affected countries. If you were to put a travel ban in effect, for example, you would have people coming into this country who we wouldn't know were here. We wouldn't even know how to find them or monitor them, and that would become a serious problem.
But if someone is flying commercial, for example, and they don't exhibit symptoms, but they've been in a region that's infected, how are you going to know that they're infected, or that they might have been infected?
I think the whole point of doing the exit screening and then the screening when they come to the United States, and then following them for 21 days, taking their temperature twice a day, is exactly so that we can see them through the end of the incubation period, and if necessary, be on top of that within hours of them exhibiting a fever.
Yeah, Mr. Torbay, same question. Would you support a travel ban under any circumstances?
No, we don't. A travel ban, first of all, we have to recognize that there are no direct flights from those 3 West African countries to the U.S. The majority of people actually transit through Europe. So a travel ban will have to include flights coming from Europe, which I don't think it will be feasible at this stage. But even with that, we can't, because if we're talking about fighting Ebola at its source, we need health professionals to be able to travel in and out of the country. We need supplies to be able to be flown into the country in order for us to contain.
And do they predominantly travel through commercial airlines?
Absolutely.
And they couldn't. Would it be prohibitive to require them to travel through charter jets?
It will be very expensive.
The question, a follow-up question. You had said earlier, and the doctor said that if there's no symptoms, there's no risk to other people. What if someone were to get onto an airplane with no symptoms, but you have an 8-hour flight to the United States from a European country, let's say, and they've been in West Africa, then to Europe, to the United States? Couldn't they exhibit symptoms on the flight? And isn't that a risk?
I very much appreciate your question and concern, and I think that is exactly why now all of the planes are being routed through the 5 airports, and why by the time a plane lands on the ground, both Customs and Border Patrol and the CDC quarantine office are notified about whether there are any sick passengers on the plane. And when they get off the plane, they're asked the same questions again, and they're given information about the symptoms of Ebola and what to do if they have any.
Thanks. I'm going to yield my remaining time to the gentleman from Florida, Mr. Mica.
Thank you. Well, first of all, what you've got in place has failed. The New York doctor just came through, and he got the temperature thing and all of that, but it failed. He self-reported. I think basically what you have is a 21-day period from where they've been subject to the infection, and people need to be quarantined coming out of those countries. You don't need a travel ban. You need to go to the people who pose a risk. I'm understanding it's only 80 to 150 coming out of those countries right now entering the United States a week. Is that right, approximate? That's what I'm told. But you quarantine them. My grandparents, when they came into Ellis Island, were subject to quarantine. We quarantined lots of people. I'll take you up to where we did it. Or they self-quarantine themselves. They pose a risk. Every traveler doesn't. But people need to be identified. We just came through the airport today at Dulles. Again, we didn't come from one of those countries, but we didn't have to. Someone could have, you just said transited. They can transit. So
the gentleman's yielded time has expired. If you could wrap it up.
Well, again, just some common sense doesn't prevail around here or anywhere. You have 21 days. Look at this guy again. Learn by his example. The 14th, he flew out. The 12th was his last day there. You count 21 days forward. So he should have been subject to quarantine, not exposing himself on the subway and other places. Then your guidance finally on
the gentleman. I'm going to do I'll do a second round. I'll come back.
But let me just finish because others went
over.
I haven't even gone over.
The gentleman have additional minute.
Okay, just an additional minute. Here's a picture. I don't know if it's true. It's New York. Your workers and how you spread this stuff. The nurses, it was either taking their things off or exposure to the skin. We don't know. Do you know, Ms. Berger? No. We don't know. Okay, here's a picture I saw. My wife told me about this. She saw it on TV. These are New York police first responders. Do you have a memo to first responders on how to deal with this stuff?
We do. We put out guidance
Here
for
they're
first
putting
responders. We had a webinar
This
for
is a
them this
press
week.
account, just a video. I don't know if it's true, but it shows them putting their gloves and other stuff and tape from the area in New York into a public trash can. So again, what you've got to do, we've got to make certain first responders, nurses, all the protective things in place where we have exposure. And we have exposure. And the testing at the airport is not working. We need a quarantine in place, period, for those coming out of there, or you're not going to stop this. The doctor was a very responsible, educated individual. Thank you.
I thank the gentleman. I ask unanimous consent the ranking member have 1 minute
Yeah,
without
Mr.
objection.
Thank you. Mr. Trabay, the quarantine, can you talk about that? I mean, I know you are interested in what's happening in Africa, but I know you're also interested in what's happening here. Can you just comment on that?
As I mentioned, one of the main pillars for actually fighting Ebola in West Africa is the ability to take staff and bring them back home. We cannot recruit staff from the U.S. or anywhere else in the world if there's a chance that they might not be able to come back home to their families and to their duties, to their other duties. And putting people in quarantine actually goes against our ability to recruit and to retain, and therefore it will go against our ability to fight the virus in West Africa.
Thank you, Mr. Chairman.
I thank the gentleman. We now go to the gentleman from Florida for 5 minutes.
Thank you, Mr. Chairman. Dr. Lurie, as I understand it, Congress in 2006 passed the Pandemic All Hazards Preparedness Act. We reviewed that and reauthorized it in this Congress, and one of the key points in that was establishing an Assistant Secretary for Preparedness and Response, which is, of course, you, and this was supposed to be the focal point for these responses. You were quoted previously as saying that you have responsibility for getting the nation prepared for public health emergencies, whether naturally occurring disasters or man-made, as well as for helping it respond and recover. It's a pretty significant undertaking, end quote. And it just occurs to me, I'm glad to see you here, but I have not seen you out front. I know communications is supposed to be part of what you do. So have you been appearing at public meetings over the last several weeks in conjunction with Ebola? Have you been participating in any briefings for the public?
Let me start by saying and repeating something I said in my testimony, that back in the spring when we first learned about Ebola in West Africa, our whole office activated to start taking action on behalf of the country, on behalf of West Africa.
No, and I appreciate that, but can you speak, since this has become heightened with the American people in the last 3 or 4 weeks, it seems like your profile has been a lot lower than some of the other folks, even though your office is a key one. So how would you respond to that?
So I think one of the things we know about dealing with public health emergencies is the public does better if there are 1 or 2 consistent spokespeople. Dr. Frieden has played the major role in that because the CDC has the lead for the public health aspects of the response.
So what would you say about this? And I appreciate that. Let me ask you this. The President had what were billed in the press as emergency Ebola meetings at the White House, one last Friday and then a week ago tomorrow on Saturday after, I guess, he played a round of golf. Did you attend either of those meetings?
Our Secretary attended those meetings, and I have met with her every single day since we got involved in this response.
But did you attend?
No, I did not.
Okay. And so has the White House or the Secretary of HHS instructed your office to stand down as being the point office in favor of this new Ebola czar?
Not at all.
Okay. So here's an issue. Thomas Eric Duncan, he brought Ebola to the U.S. Your office is clearly what was envisioned in this legislation, and yet he was able to bring the disease here. So what were you guys prepared in your office for Thomas Eric Duncan, or did you drop the ball and could you have done some things better?
So what happened with Mr. Duncan required a whole system to work, right? It required the federal components to be in place. It required state and local health departments to be in place. It required hospitals to be in place. And it required individual health providers, doctors or nurses, all to be able to do their job. Certainly, there were some breakdowns and links in the chain. Do I think that we've done a good job preparing hospitals and the healthcare system in our country for disasters? Yes, I do. Do I think we are being very aggressive now about preparing health professionals and healthcare providers and institutions to be able to recognize, treat, and isolate cases of Ebola? I think we are being very, very aggressive about that.
So how would you explain to me then, so the Pandemic Act seemed to have your office being kind of a point person within HHS. Now we have this Ebola czar. So how does the chain of command work in terms of how we're confronting Ebola at this stage? Is the HHS assets, is everyone reporting to Ron Klain now, and then Klain is directly reporting to the President? What's your understanding of this?
So Mr. Klain's role and responsibility is to coordinate all the different aspects so that we are increasingly working in a whole-of-government response. It's to make sure that all the parties are working together on a day-to-day basis to make decisions.
But isn't that in your job description anyways? I mean, aren't you kind of a czar to deal with these pandemics?
So I have responsibility for dealing with medical and public health emergencies, particularly domestically. And the other thing that I think it's really important to recognize is that the bulk of this response is a global health response. It's not a domestic response. My office has been active along with the CDC, the NIH, the FDA, in meeting with the Secretary since the beginning of this, as I said, almost every day.
Well, I appreciate that. I know that the Chairman invited Mr. Klain here. I wish he would have come so we can ask. Some people, as Mr. Gowdy pointed out, may have some reason to question whether this is the right individual to actually execute the medical component of this, or whether this is more for political reasons. I would have liked to have been able to ask him some questions to try to probe that further.
Would the gentleman yield?
Yes.
For the record, we did invite him. We'd hoped he'd be here. We also invited the World Health Organization representative, and as you know, we fund about half of their entire budget. And their answer to us was that basically they don't do congressional hearings. So I'm sending a letter to the appropriators letting them know they don't do congressional hearings about how they're spending our money and how they're going to fight something like this. But it is an area of concern, as you say. You've got an attorney who's been hired to do this as a czar. You have the World Health Organization, and neither wanted to appear. I yield back. We now go to the gentleman from Georgia for 5 minutes, Mr. Collins.
Thank you, Mr. Chairman. I appreciate each being here in the sense, and there's a lot that has concerned me from this hearing. Actually, I came into this hearing hoping, in some ways, got some assurance, but in also other ways, very concerned about some of the answers that were given. And I may get to that in a moment, but I want to focus on, being from Georgia, I want to focus on a positive note, and I want to focus on something that was really, because back when Dr. Brantley, Ms. Wright-Bowles, which seems like an eternity ago now, were brought to the United States, they came to really the constituents, my constituents started feeling fear. A lot of people were concerned this is something that we don't understand and how you get it. And then in the weeks and days after that, the conflicting and inaccurate public statements that followed the arrival from CDC, others, and as it just went ahead, have caused even more panic. In fact, today in one of my local press outlets, there is basically just an opinion poll where people can click in and says 75% believe that the CDC's information from the beginning of this was just inaccurate and not helpful. You have a level of trust that is gone with many people. But what happened here was really time to switch gears and say that frankly, from my perspective, Georgia got it right. Emory got it right. Nebraska has got it right. There's some places that have got it right. And what I want to know is, as we continue this process, as we look at the precautions, we look at the things that are going on, is focus on the protocols for like Ms. Berger and the nurses and the folks who come into the very front stages of this. They do it in a way that they follow protocol, they have the protocols in place, and have the equipment in place. And I think this is what I want to commend Emory University in Atlanta for being able, the first hospital to successfully treat an Ebola patient and actually see that. And actually the fourth, Amber Vinson, is our understanding is still recovering at Emory and has been declared Ebola-free. That is a good thing. Emory did this because they were set up with the CDC on those levels that we heard about here, Dr. Lurie, on the tabletops. They worked with CDC. They were one of those outlets in case something happened, which the CDC is in Georgia as well, most of which I am so proud of. except some of the public statements by the director, who has really lost confidence of many in this Hill and many in the country by the statements that were made and the actions that he took. For him to be the face is really a concern of this. So the question that I have is, in looking at this, Emory has put out a lot of great stuff, and with unanimous consent, Mr. Chairman, I'd like to add the editorial from John Fox, who is the President and Chief Executive Officer of Emory Healthcare, beating Ebola through a national plan.
Without objection, the entire article will be placed in the record.
And I do appreciate that, and because I think this is a national response. You said something just a moment ago, Dr. Lori, that I'm not going to focus on, but you said you were looking, this was not a domestic, this was a global issue. Well, aren't we part of global? So what part would you be missing in understanding of how that would affect us? In fact, when your main concern was if it was something overseas, when we have places like Emory and Nebraska doing it right, we have those doing the protocols that were not forced upon them, they had it ready to go. Was it not, shouldn't it not have been a part of your job?
Maybe you misunderstood what I was trying to convey. What I was trying to convey is—
Very quickly enlighten me.
Okay. So I have domestic responsibilities for preparedness. In fact, one of the things that I was reflecting on when I was listening to your comments is that prior to taking this job, I had an opportunity to go around to every county in Georgia with your Georgia public health officials and do those tabletop exercises for biopreparedness. I spoke to the leadership at Emory yesterday, and we are very grateful for their incredible response in their leadership, not only in taking care of the patients at Emory, but now helping us and helping the rest of the country as we build out and develop a regional strategy for taking care of Ebola patients.
And I appreciate, and that is, because I do want to be, at least, let's accentuate the positive, the healthcare workers that are getting it right. But I share, Ms. Berger's concern, and there was some other, discussions lately, is, let's say they did switch planes. There's not a tracking. They don't fly into one of the five airports. They come in different ways and then present at an emergency room, which, by the way, in my area, a lot of times poor area, they do go to the emergency room with flu-like symptoms all the time. All the time. It's part of the problem we've got. And it's going to get worse. So the people who do ask for those questions, having them trained, having them adequately prepared, and I think this is the part that concerns me. And you made this statement, and I'm just going to end here because there's the concern out there is for the people to understand what is done right, Emory University, Nebraska, and those kind of things that have done what it took to follow protocols and be prepared. That's the number one. From the CDC level and the spokesman level, there's been a disastrous failure at that. There's been now, with Mr. Klain, a disastrous failure in at least perception that we're taking this health care seriously, not just an administrative assistant. We needed someone else that has the credentials that you have or others. But here's my problem. After we discussed everything on when they actually got here, the doctor in New York, which I was in New York, just came back last night and came this morning, up there seeing what's going on. Here's your response, and it's the response that the American people cannot hear anymore, and that is, after it happened, out of an abundance of caution, we cleaned the bowling alley. Out of an abundance of caution, we went back. The American people need to see the abundance of caution beforehand. That is your job. That is the job of the CDC and the job of preparedness. And they wanted to see the abundance of caution before our health care workers were put at risk, before our system was burned. And that's where the abundance of caution needed to come. And from that, from a very positive statements from Emory University and Nebraska and others who did it right, and I want to congratulate them, I want to also highlight that abundance of caution should have started a while back, not after the fact. And with that, Mr. Chairman, I yield back.
I thank the gentleman. We now go to the gentleman from Florida, Mr. Micah.
Well, perfect lead-in. Now, you sat here and told us you're responsible for both domestic preparedness and a global response.
No.
What are you doing?
No, my responsibility is a domestic responsibility primarily.
Okay, so you have nothing to do with the global response. Here's more from this article about WHO, who wouldn't come here today. First of all, this is the worst Ebola outbreak in history. Is that right? No, is that not right? Okay. And it says the World Health Organization said today it would probe complaints that had been too slow to wake up the scale of Ebola. Then it says critics have questioned why WHO only declared an international health emergency in August, 8 months after the epidemic began. And did the administration or anyone in a position of authority from the United States, where we spend millions of dollars into WHO, ask them to proceed?
So let me
No,
put a,
did
let me
they-
put a
did-
finer let me put a finer point
Do
on
you
this.
know if they did? You could say you don't know.
Do I don't know if they did what?
If we did anything, is there a letter or anything? Did we go after who? This is a global disaster.
We've been working with
put lots of
WHO.
money in the World Health Organization. And where's the and this isn't my stuff. I'm just reading you what I'm telling you that people are coming after. Okay, this isn't a panic. It's to be prepared. Now, are you in charge of being prepared?
I am in charge of being prepared.
Okay, then I think you need to turn your resignation in. Have you read this report? Have you read this report about preparedness that the IG, do you have some authority over preparedness at DHS?
I have no authority over
Then
preparedness
you
at
don't have the
DHS.
authority to do the job. Who has the authority to do the job? He's just prepared for this committee. It's dated the 24th. He says the stuff they bought, nobody knows even the inventory, where it's gone. You've got equipment to protect people that's out of date. It won't protect them. I even put up hand sanitizers. They looked at 84% of them are expired. Is that your job or somebody else? And if it isn't your job, is it the new czar's job? Whose job is it to protect the American people?
First, let me clarify that DHS has responsibility to buy personal protective equipment for its staff.
Well, have you been over there to see what they have?
And that's
have
what
you
this
been over
report-
there to see what they're doing and have? Have you seen this report? Folks, staff, make sure she gets a copy of this report. This is a scathing report. Page after page, the inventory, outdated stuff that we bought. We spent millions of dollars and we aren't prepared. Let me ask you another question. Having been here a while, I was through the bird flu. This is transmitted even by an individual. And if it takes inconveniencing, and first of all, you should quarantine the healthcare workers. You're wrong, Mr. Torbay. They're the most exposed to this. So anyone who has been exposed for 21 days coming into the United States must be quarantined. I don't care if it's inconvenience. They should recognize their own risk too. And we should watch those people. You had one guy come in yesterday. He got to his, 18th day or something, came down with it. Okay? So I think, and it may not be that many healthcare workers, but they're the most exposed, unless you're burying the people like you just saw with a photo from him. If you're burying people or you're in the medical, you quarantine those people for their own risk, even if we pay for it to keep this thing from spreading. Right now, we're lucky. Okay, we don't know what infected the nurses. We don't know, again, if there'll be other cases. But you have to take steps in an emergency situation like this. She claims she doesn't have the authority to see what DHS has to keep us prepared. Somebody needs to see that we are prepared. Again, this isn't panic. Last question. Okay, bird flu. I was involved in bird flu. These people are coming by planes. When some plane comes in from Africa or transit through and has passengers from there, what are we doing with it, the plane?
With the plane itself?
Yeah, the plane. They've been on the plane. They might have barfed in the plane. There might be excrement. There may be vomit. There may be body fluids. He sat in a seat. And we don't know. We don't know if those nurses got it from taking off equipment incorrectly or if it touched their skin.
There are
you just
protocols for
testified
cleaning
earlier
the plane.
that perspiration would do it. So
there are protocols for cleaning the
I
plane.
want to know the protocols that are in place. I've seen the equipment that we have, and Center for Disease Control actually got some then, and we could bring up it's a heating device. It heats the plane to 140 degrees to kill the germs, and that's what we used in the bird flu. Are we doing anything like that to make sure those planes aren't little Ebola transporters?
Yeah, Mr. Mica, you sound upset, and I'm sorry for
I'm
that.
not upset. I'm a happy boy.
But we will make sure that you get the protocols
But I'm
for
not
cleaning the
happy
plane.
I'm not happy with, again, you told me you're responsible for preparedness. Now, and if that's not your responsibility, is it the new guys? Does he have the ability to go in and make certain that we are prepared? Well, it hasn't hit here yet. But what you want to do is be prepared. The Boy Scouts marching song, be prepared. We spent millions of dollars, and this Inspector General of the United States of America has gone in at our request and looked at what one agency is doing to be prepared. In its scathing report, we are not prepared. So you go back to the other guy who didn't show up today, the new czar. We want to work with you. We don't want the American people at risk. We've already been through this, as I said, with bird flu. Are those planes being properly sterilized? Because this can spread, okay? It hasn't spread. We aren't at risk right now. And then the protocols. You give to the committee and put in the record. I want to see the first responders. I want to see the first responders' direction. And then I'll put these pictures of the videos from New York disposing of the gloves and the masks.
Without objection, to be placed in the record.
Well, we'd be happy to get you those protocols and the protocol for cleaning the plane, and I very much look forward to working with you and other members of Congress as we move forward with this.
Thank you.
Thank you. I'm not going to.
I have a plane to catch.
I thank you, and have a safe flight. It will be about your 12th in 4 days. I'm not going to ask a second round of questioning, but I do want to ask just one question, and then we'll go to Mr. Cummings for his close. There was a statement made just, it seems like an eternity ago, but about maybe 15 minutes ago, about following people for 21 days after they land. Dr. Lurie, currently there is no visa restriction or law that gives you specific authority. Do you believe you have the authority under existing public health laws to force follow-up daily temperature checks and the like? Let's just assume for a moment we take the gentleman from Florida's analysis that a plane comes in, a person tests, let's just say elevated temperature for a moment, whether they test positive later or not. For the other people on the plane, do you have the authority then to compel them to go to be tested, or is it just hope for the best that they'll recognize a high temperature and report it?
Now, I believe that we have the authorities that we need, but, we're constantly looking at and updating our policies based on the situation at the time. And so we will continue to look and be sure we have the authorities that we need.
Okay. In addition to asking for those protocols, which you've already said you're willing to give us, I'm going to direct the committee to, in fact, ask questions of you and other areas, and of course our new czar, as to specific authorities you may have that would support requiring people. There's been a lot of discussion about restrictions on people's travel, and I agree, quite frankly, with many of the people here that it sounds like a great idea, it's a great soundbite, but then when you actually try to figure out how you would stop somebody from leaving Sierra Leone, going to Paris, spending a day there, then booking a flight here, the practical reality could well be that it would be circumvented. However, the question of a plane load of people coming in, and I came in this today into Washington, D.C. I came in with a Marine major. I came in with a Marine major who has a cold and who has many of the symptoms. And he did not go through a check. They're not doing temperatures. If he later reports, the whole question from a public health standpoint of are we prepared to locate and to mandate surveillance on people so that after the fact we can accurately do a containment is one that I'm directing the committee to ask a series of questions, and Doctor, your organization obviously be part of it.
Yeah.
Would
you give me a moment, since you talked about the guy with a cold, to do a quick educational soundbite? Anybody?
This will be your closing statement, Doctor.
Sure. Anybody who has a fever or flu-like symptoms during this season ought to be asked to provide a travel history to look at whether they've been out of the United States in the past 21 days and whether they've been in one of the affected countries.
I couldn't agree with you more. And if I get a fever having been in Iraq, Kuwait, Saudi Arabia, UAE, and additional places, meeting with people, many of whom have traveled to Africa recently, I will be the first to rush to the hospital to report. With that, we go to the gentleman from Maryland.
Thank you very much, Mr. Chairman. First of all, I want to thank all of our witnesses for being here today. And I must tell you that I can understand the emotion of the American people when there is an issue of life and death, and when you have people who put their lives on the line to take care of the sick, not knowing whether they will become sick themselves. That's serious business. When you have our military going across the sea to try to make a difference, as I always say, change the trajectory of somebody's destiny. And the idea that they may come back with a disease that could possibly kill them, that's serious business. So, you know, as I listen to you, Mr. Lumpkin, and you, Major General, I have absolutely no doubt that you will do everything in your power to protect our military. I have no doubt about that. And I think that if you find that as you go through the procedures that you have in place, if you feel those procedures need to be changed or even tweaked so as you might be more effective and efficient in that goal, you will do that. Is that correct?
That is correct.
And you, Dr. Lurie, I want to thank you for what you're doing. And one of the things, I guess, that really concerned me, you know, when I looked at Dr. Lurie, and I saw all those health workers, nurses, I guess it was, and then I see Ms. Berger sitting next to you, and then I hear about people not being properly trained in the hospitals. I think it would be almost legislative malpractice for me not to ask the question, and it may have been asked before when I was out the room, how do we make sure that those folks receive the training? They're not just running around saying, you know, I'm just complaining to be complaining. They want to be the best. They don't mind. They don't mind putting their lives in danger. But they want to know that everything possible to make sure that they're safe, they want to make sure those things are in place. And I am so glad that Nurse Pham has been found to be Ebola-free now. But how do we make sure that they know that? And Ms. Berger talked about an executive order, and then the chairman was asking you about, Ms. Lurie, Dr. Lurie, whether you had all the things you need to be able to do what you need to do. I got to ask you, how, when you listen to Ms. Berger, and Ms. Berger, I watched you on television, I know your passion, no, I'm serious, I feel it. It's contagious, and it is strong, and I know you care about the people that you represent, no doubt about it. So how do we do that? I mean, Dr. Lurie, help me.
Sure. Well, first let me say Ms. Berger and I and probably every nurse in America share the same goal, to keep them safe, to be sure that they are trained, to be sure that if they're frontline providers, that they have the education, the knowledge, the adequate PPE, the training, and the exercises to stay safe. So I can tell you a little bit about what we've been doing. We have been reaching through the top. We've got a very comprehensive now national education program going on. We've reached through the top for all the hospital associations, through all the hospitals, through the nursing associations. I was on the phone with 10,000 nurses the other night, and there were more that wanted to get on the phone. And we have said to them all, please, if you're a hospital, conduct a medical and a nursing grand rounds. Do first patient training, do first patient drills and exercises. Make sure that your nurses are trained and your frontline nurses have to practice putting on PPE to proficiency. Okay? Have policies, plans, and protocols in place and drill and exercise them. We've said to the nurses and other frontline health professionals, here is the guidance. Please be sure that the checklists and other things are posted in your places of frontline care. Please ask your hospitals and your administrators to be sure that there are plans, practices, and policies in place, and that you have the PPE required to do your job. We've said to state and local health departments, we would like you to call every hospital in your jurisdiction, find out if they've put those plans in place, find out if those exercises are in place, find out if that PPE is in place, and report back to us. And we will continue to be reaching out with material, with training, with education opportunities until we've got this done.
Ms. Berger, this is your moment. This is your moment. Dr. Lurie just talked about, I hope you don't mind, Mr. Chairman, this is important. Dr. Lurie just talked about what they're going to do, what they're doing. Those ladies that were behind you today, they want to know, some of them left now, but they want to know that they're going to be protected. Now, you heard what she just said. Can you just react? And maybe you might want to give her some advice as to what you all, and I'm not trying to be smart, I'm serious. This is a critical moment. Go ahead.
The nurses that were here had legislative visits. They are fully engaged in this hearing, and they appreciate the opportunity to be here. What I would like to say is that until the CDC guidelines and training and education and personal protective gear at an optimal level are mandatory, no matter how good the guidelines are, no matter how good the intentions are, we need to ask Congress to step up and do what's right for the United States of America and its citizens by making sure the frontline caregivers have mandatory, optimal standards for protective gear and training and education.
So there is a gap, Dr. Lurie. Am I right? Based upon what she just said. In other words, you may be saying all these one things, but then it's a whole other thing for the hospitals to provide the things that you tell them they need to go and get. Am I right?
I think Ms. Berger and I share the same goal, and I share the same goal as I said, with most nurses and nursing organizations around the country, and look forward to working with them moving forward so that we can be sure that nurses across this country who put themselves on the line of fire every single day with other frontline healthcare providers are safe.
As I close, I just want to thank you, Mr. Turbay, for your testimony. And I want to say to all of us, it goes back to we have to address the issue here in America, no doubt about it. But we also have to go back to the source. We got to do that. And I think, Mr. Turbay, your testimony about some basic things that are needed, such as food, vehicles, fuel, staff, supplies, resources, things that can be, that will allow us to try to stop this in Africa so that it does not continue to come to our shores, is so very, very important. And I just hope that the Congress is listening to you, and I realize that we need more international partners. I think that's what you just told us. People coming in and helping this, because this does not just affect Africa or the United States. In fact, it affects the world. And so I don't know how we convince folks that is other countries, to do more to get up to that $988 million figure. But we got to figure out a way to do that. Would you agree? And then I'll close. I'm close.
Absolutely. I fully agree with you. I think the whole world needs to realize that we are all in this fight together, and the resources need to be available until we get this virus under control. And at the same time, I'd like to thank the committee for its leadership on this issue, as well as the U.S. government and its agencies for taking the lead in responding to the Ebola crisis. They've been doing a tremendous job, and we're very proud to be part of it.
Thank you, Mr. Chairman.
Thank you. I want to thank all of our witnesses here today. In closing, I'm going to make a comparison, and I think it's an important comparison for the American people, to put it in perspective. As was alluded to earlier, I just came back from what has become a theater of operation in Iraq, where ISIS, now like an ugly, resilient virus or infection, has shown up again, and Islamic terrorism is murdering people far away. While I was there was a murder in Canada, and around the globe, small but significant events occur in which we realize that terrorism does not stay in the country that we think it begins in or is prominently in. In the war on terror, we rely on the Department of Defense and our U.S. military as our primary way to eliminate those actors in faraway places like Iraq, Afghanistan, and Syria. We also rely on the Department of Homeland Security to deal with a comparatively small risk, small event here in the United States, whether it's 9/11, which was horrific, and led to its founding, or the occasional lone actor or small group that try to conduct terrorism here in the United States. It's that teaming of the large effort at the source and, in fact, an equally important effort at home for the relatively isolated cases that come through that seem to be so close to the problem we're facing with Ebola. Ebola is, in fact, a disease that has periodically reared its ugly head for more than 3 decades. It will, in fact, until there's a cure, rear its head again. Like many diseases in which a virus, eventually we find a cure, that cure is only good if everyone takes it. The idea that we're going to find a shot in a country in a continent of 1 billion people living mostly in poverty means that even when we find it, it may in fact be there for generations. And like smallpox, tuberculosis, and others, they never seem to be completely gone. Our effort, and the effort that all of you articulated very well today, has to be, first of all, in Africa, at the source. There, World Health Organizations, USAID, and once again the United States military have and are taking up the fight against this dreaded disease. Mr. Roth, your testimony and the testimony that I believe we'll have following this, that the Department of Homeland Security has an obligation, a unique obligation, one in which they were formed to deal with things which threaten the home front, Ebola, and particularly the movement of people who may be infected, falls squarely within their jurisdiction, and they seem to have not been prepared. So as we conclude here today, it is my view that we will be doing both public and non-public investigation in the weeks and months to follow, looking for transparency, and Dr. Lori, you said this very well, transparency to the American people. What we tell nurses and doctors and healthcare professionals, we need to tell the public. Because unlike some things where the first responder is in fact the greatest threat, the first responder with Ebola is not the first to come in contact with the infected individual. Almost in every case, there will be a cab driver, a bus driver, family, friends, and others who will already have had an unprotected contact by the time a first responder is aware that there may be a problem. By the time that person suits up, he or she already will in fact be exposed. So as we begin looking at the protocols, I think we have to understand one thing. There is no perfect solution. There is no way that every American is going to place themselves in a hazmat suit from morning until night. To deal with this disease, we will have to go to its source. We will have to work together with our partners around the world to eradicate it in Africa, because ultimately, like terrorism has been to the American people for more than a decade, this disease will not, in fact, be eradicated if we wait till it comes to our shore. So I thank you. I believe this was a worthwhile hearing. I thank Mr. Cummings and the tremendous turnout of members who came back on the eve of their elections for this important hearing. And with that, we stand adjourned.